What if everything your doctor told you about heart disease was only half the truth? What if the real enemy destroying your arteries right now is not the butter on your toast, not the eggs on your plate, not even the occasional slice of pizza, but something invisible, something happening silently inside your blood vessels every single second of every single day, and nobody is talking about it loudly enough? What if plaque has already begun building inside your arteries, and you feel completely fine, completely healthy, completely unaware? Because that is exactly how this silent killer operates. What if I told you that millions of people who considered themselves perfectly healthy woke up one morning, or never woke up at all, because arterial plaque had been constructing its deadly architecture for 20, 30, 40 years without a single warning signal? What if stopping this process, even reversing it, was genuinely possible, but the information you needed was buried under decades of outdated medical advice? Today, everything changes. Today, you are going to learn what is truly destroying your arteries, what science actually confirms about plaque formation, and most powerfully, what you can do starting today to stop it, reverse it, and reclaim the cardiovascular health that every single human being deserves. Stay with me. Every second of this matters. What if the heart attack that kills someone you love, or kills you, was entirely preventable, not through expensive medications, not through complicated surgeries, but through understanding one fundamental biological truth that mainstream medicine has systematically underemphasized for decades? What if the plaque building inside your arteries right now began not because you ate too much fat, not because you were genetically cursed, but because of a process so common, so ordinary, so deeply embedded in modern daily life that you have been unknowingly accelerating it every single day without realizing it? That question is not hypothetical. That question is the difference between life and death for hundreds of millions of people on this planet. And today, we're going to answer it completely, honestly, and with the kind of scientific depth that will permanently change how you think about your cardiovascular system. Let us begin with the single most important and most misunderstood concept in all of cardiovascular medicine, and that concept is inflammation. Not inflammation the way most people think about it, the redness and swelling you see when you cut your finger, the temporary immune response that heals a wound. I am talking about something far more sinister, far more persistent, far more dangerous. I am talking about chronic, low-grade, systemic inflammation, the kind that produces no obvious symptoms, generates no visible swelling, causes no immediate pain, but burns silently inside your blood vessels like a slow, invisible fire that never fully extinguishes. This is the true initiating event in arterial plaque formation. This is where the story of cardiovascular disease actually begins, and almost nobody is telling this story loudly enough or clearly enough. Your arteries are not simple tubes. They are living, breathing, biologically active structures lined with an extraordinarily thin and extraordinarily important layer of cells called the endothelium. This endothelial lining is, in many respects, the most important tissue in the human body because it regulates blood flow, controls vascular tone, prevents clotting, modulates inflammation, and maintains the absolute barrier between your bloodstream and the deeper structural layers of your arterial walls. When the endothelium is healthy, when it is intact, when it is functioning the way nature designed it, cholesterol does not embed into arterial walls. Plaque does not form. Cardiovascular disease does not develop. The endothelium, when healthy, is your greatest cardiovascular protection. But when the endothelium becomes damaged, when that microscopic lining becomes inflamed, dysfunctional, permeable, everything changes in ways that are catastrophic and cumulative. Now, what damages the endothelium? This is the critical question, and the answer is going to challenge everything you think you know. The primary drivers of endothelial damage and chronic arterial inflammation are not simply dietary cholesterol. They are oxidative stress, meaning an overwhelming excess of free radicals that literally tear apart cellular structures. They are chronically elevated blood sugar, which through a process called glycation, essentially coats and destroys the delicate proteins that maintain endothelial integrity. They are chronically elevated insulin, independent of blood sugar itself, which promotes inflammatory signaling cascades inside arterial tissue. They are chronic psychological stress, which floods the body with cortisol and adrenaline in amounts and durations that the human body was never evolutionarily designed to sustain. They are cigarette smoke, which delivers thousands of oxidative compounds directly into the bloodstream with every single inhalation. They are trans fats and highly processed seed oils, which incorporate into cell membranes and fundamentally alter the inflammatory characteristics of every cell they touch. and they are chronic sleep deprivation, which disrupts the hormonal and inflammatory regulatory systems that your cardiovascular system absolutely depends upon for nightly repair and restoration. When the endothelium becomes damaged by these forces, the body does something that is, in its original biological intention, quite intelligent. It sends LDL cholesterol particles to the site of damage as a repair mechanism. Cholesterol is not inherently the villain of this story. Cholesterol is actually attempting to heal a wound. The problem begins when those LDL particles, already circulating in an environment of oxidative stress and inflammation, become oxidized themselves. Oxidized LDL is a fundamentally different and fundamentally dangerous substance compared to native, healthy LDL. Oxidized LDL is recognized by the immune system as foreign and dangerous, which triggers macrophages, your immune cells, to engulf these oxidized LDL particles in massive quantities. These engorged macrophages, now swollen with oxidized cholesterol, are called foam cells. And foam cells are the literal structural building blocks of arterial plaque. They accumulate beneath the endothelial lining, they die and release their toxic contents, they trigger further inflammation, they attract calcium deposits, they recruit more immune cells, and they gradually, progressively, silently build the fibrous, calcified, deadly structure that we call atherosclerotic plaque. This process does not happen overnight. It begins in childhood. Studies examining the arterial tissue of young people, teenagers, young adults in their 20s, who died in accidents have consistently found early-stage plaque formation already present. By middle age, in the majority of people living modern Western lifestyles, meaningful plaque burden already exists inside the coronary arteries. By the time a person experiences their first chest pain, their first cardiac event, the arterial damage has typically been accumulating for 20 to 40 years. This is the terrifying reality of cardiovascular disease. It is decades in the making, and it is almost completely silent until a catastrophic event occurs. A heart attack is not something that happens suddenly. A heart attack is the endpoint of a decades-long biological process that could have been interrupted at almost any point along the way. Now let us talk about blood sugar, because the relationship between glucose metabolism and arterial health is so profound, so mechanistically clear, and so broadly ignored in public health messaging that it genuinely represents one of the greatest failures of modern medical education. When blood glucose rises above optimal levels, and understand that the damage begins well below the threshold at which diabetes is formally diagnosed. Sugar molecules attach to proteins and lipids throughout the body in a process called glycation. Glycated proteins are structurally altered, functionally impaired, and powerfully pro-inflammatory. The endothelium is particularly vulnerable to glycation damage because of its constant direct exposure to everything circulating in the bloodstream. Every spike in blood sugar above approximately 100 milligrams per deciliter creates measurable oxidative stress within the endothelium. Every episode of hyperglycemia generates advanced glycation end products, which are abbreviated as AGs. And the naming is not coincidental, because these compounds accelerate biological aging of vascular tissue with remarkable efficiency. People with type 2 diabetes have 2 to 4 times the cardiovascular risk of metabolically healthy individuals, not primarily because of high cholesterol, but because of chronically elevated glucose and insulin causing continuous endothelial damage, continuous glycation, continuous oxidative stress, and continuous inflammatory cascading throughout the arterial system. But here's the critically important and broadly underappreciated truth. You do not need to be diabetic to be experiencing meaningful glucose-driven arterial damage. The standard medical definition of prediabetes begins at a fasting glucose of 100 milligrams per deciliter. Arterial damage from glycation and oxidative stress becomes measurable at lower levels than that. Tens of millions of people with completely normal fasting glucose but impaired glucose tolerance, meaning their blood sugar spikes excessively after meals and remains elevated longer than it should, are experiencing ongoing arterial damage that no standard blood panel will reveal without specifically testing for it. Insulin resistance deserves its own dedicated discussion because it is both extraordinarily common and extraordinarily underdiscussed in the context of cardiovascular risk. Insulin resistance means that the cells of the body have reduced sensitivity to insulin signaling, requiring the pancreas to produce ever-increasing amounts of insulin to accomplish the same glucose regulatory task. Chronically elevated insulin, hyperinsulinemia, is independently pro-inflammatory. Insulin at high concentrations promotes the proliferation of smooth muscle cells within arterial walls, contributing to arterial stiffening. High insulin increases the production of inflammatory cytokines. High insulin promotes the retention of sodium and water by the kidneys, elevating blood pressure and creating additional mechanical stress on the arterial endothelium. High insulin upregulates lipogenesis, the production of fat, in the liver, generating more small, dense LDL particles, which are the specific LDL subtype most prone to oxidation and most capable of penetrating the endothelial layer. Insulin resistance is not simply a blood sugar problem. It is a whole-body inflammatory and vascular disease that happens to be measurable through glucose and insulin markers. The dietary contributors to arterial plaque formation are more nuanced and more interesting than the conventional fat is bad narrative that dominated medicine for the latter half of the 20th century. Refined carbohydrates and added sugars are now recognized as among the most potent dietary drivers of the inflammation, oxidative stress, insulin resistance, and dyslipidemia that collectively accelerate plaque formation. The sugar industry's decades-long campaign to shift blame for heart disease from sugar to saturated fat, a campaign that involved funding research, influencing regulatory bodies, and shaping medical education, represents one of the most consequential acts of scientific manipulation in modern history, and the cardiovascular mortality statistics of the past several decades reflect the devastating human cost of that manipulation. Industrial seed oils, soybean oil, corn oil, sunflower oil, cottonseed oil, rich in omega-6 polyunsaturated fatty acids, are extraordinarily prone to oxidation during processing, during cooking, and within the body itself. These oxidized lipids directly damage the endothelium and contribute to the formation of oxidized LDL. The ratio of omega-6 to omega-3 fatty acids in the modern diet has shifted from a historically observed ratio of approximately 4:1 to a current estimated average of 15:1 or even 20:1 in heavily processed food environments, a ratio that chronically biases the inflammatory regulatory systems of the body toward a state of persistent, low-grade inflammation. Trans fats, partially hydrogenated vegetable oils, deserve special mention as perhaps the most purely arteriotoxic substance ever introduced into the human food supply at industrial scale. Trans fats simultaneously raise LDL cholesterol, lower HDL cholesterol, promote inflammation, impair endothelial function, and increase the oxidizability of LDL particles, achieving in a single dietary component nearly every cardiovascular risk mechanism simultaneously. While trans fats have been largely removed from most processed food supplies following regulatory action in various countries, they remain present in small amounts in many products, and they remain present in the food supplies of many developing regions of the world where regulatory oversight has been slower to respond. Now let us speak about stress, because chronic psychological stress is a cardiovascular risk factor of remarkable magnitude that is consistently underemphasized relative to its actual biological impact. When the body perceives a threat, whether that threat is a predator in the ancestral environment or a hostile work environment in the modern one, it activates the hypothalamic pituitary adrenal axis and the sympathetic nervous system, releasing cortisol and catecholamines, including adrenaline and noradrenaline. In the ancestral context, this response was brilliant, perfectly calibrated, and self-limiting. It mobilized energy, increased heart rate and blood pressure to perfuse muscles for fight or flight, and then resolved completely when the threat passed. In the modern context, millions of people exist in a state of chronic, unrelenting, low to moderate stress activation that never fully resolves. The cortisol never drops back to baseline, the sympathetic nervous system never fully disengages, the inflammatory response that cortisol should suppress becomes paradoxically amplified through chronic receptor desensitization. Chronically elevated cortisol promotes visceral adiposity, the accumulation of fat around the abdominal organs, which is itself a major source of inflammatory cytokines. Chronic stress increases blood pressure, accelerating mechanical damage to the arterial endothelium at the bends and branches of arteries where turbulent flow already creates vulnerability. Chronic stress increases platelet aggregation, raising the risk of blood clot formation on top of existing plaque. And chronic stress powerfully impairs sleep quality, initiating a secondary cascade of cardiovascular damage through sleep deprivation mechanisms. Sleep, and specifically the chronic deprivation of adequate sleep, represents one of the most powerful and most underappreciated cardiovascular risk factors in existence. During deep sleep, the body engages in profound cardiovascular repair processes. Blood pressure drops significantly during deep sleep stages, a phenomenon called nocturnal dipping, allowing the arterial system to rest and recover from the mechanical stress of daytime pressure. Growth hormone, which promotes vascular repair and regeneration, is secreted primarily during deep slow-wave sleep. Inflammatory cytokines are regulated and suppressed during adequate sleep. The glymphatic system, which clears metabolic waste from neural tissue, is most active during sleep, and disruption of this system has been linked to systemic inflammatory states. People sleeping fewer than 6 hours per night consistently demonstrate elevated inflammatory markers, including C-reactive protein and interleukin-6, elevated blood pressure, elevated cortisol, impaired glucose tolerance, and increased cardiovascular event rates across virtually every epidemiological study that has examined the relationship. Adequate, high-quality sleep is not a lifestyle luxury. It is a cardiovascular non-negotiable. Physical activity, or more precisely, its chronic absence, profoundly shapes arterial health through multiple mechanisms. Regular aerobic exercise promotes the production of nitric oxide by the endothelium. Nitric oxide being the single most important signaling molecule for vascular health, responsible for arterial dilation, inhibition of platelet aggregation, prevention of inflammatory cell adhesion to the endothelial wall, and maintenance of the flexible, responsive arterial tone that characterizes cardiovascular health. Exercise also improves insulin sensitivity, reduces visceral adiposity, lowers blood pressure, shifts the LDL particle profile from small dense to large buoyant, raises HDL cholesterol, reduces inflammatory cytokines, and promotes the development of collateral circulation, meaning alternative arterial pathways that can maintain blood flow even if primary arteries become partially obstructed. Sedentary behavior, by contrast, allows endothelial nitric oxide production to decline, insulin resistance to develop, visceral fat to accumulate, and the entire inflammatory regulatory milieu of the cardiovascular system to drift progressively toward a pro-atherogenic state. Now, having understood what causes plaque to form, let us discuss with equal depth and equal scientific rigor what can be done to stop it, slow it, and in meaningful ways reverse it. The first and most powerful intervention is addressing insulin resistance and glycemic control through dietary modification, reducing the glycemic load of the diet, meaning reducing the quantity and speed with which dietary carbohydrates elevate blood glucose, is among the most mechanistically direct ways to reduce endothelial glycation, reduce oxidative stress, reduce inflammatory cascading, and reduce the production of small, dense LDL particles. This does not necessarily require extreme dietary restriction or ketogenic approaches for everyone. It requires a thoughtful and substantial reduction in ultra-processed foods, refined grain products, added sugars, and sugar-sweetened beverages, combined with an increase in fiber-rich whole food carbohydrates, adequate protein, and healthy fats that do not promote inflammation. Omega-3 fatty acids, specifically the long-chain marine omega-3s, icosapentaenoic acid, and docosahexaenoic acid found in fatty fish and quality fish oil supplements, represent one of the most robustly evidence-supported nutritional interventions for cardiovascular protection. These fatty acids reduce triglycerides, reduce inflammatory cytokine production, improve endothelial function, reduce platelet aggregation, stabilize cardiac electrical rhythm, and in high-dose supplementation studies have demonstrated meaningful reductions in major adverse cardiovascular events. The REDIS-IT trial demonstrated a 25% reduction in major cardiovascular events with high-dose EPA supplementation in a high-risk population, a magnitude of benefit comparable to many pharmaceutical interventions. Increasing omega-3 intake while simultaneously reducing omega-6 rich industrial seed oils is a dietary strategy with genuine, substantial, mechanistically coherent cardiovascular benefit. Magnesium is a mineral whose cardiovascular importance is dramatically underappreciated in mainstream medical practice. Magnesium is a cofactor in over 300 enzymatic reactions, including those involved in ATP production, DNA synthesis, protein synthesis, and, critically, the regulation of vascular smooth muscle tone and blood pressure. Magnesium functions as a natural calcium channel blocker in vascular tissue, promoting arterial relaxation and reducing blood pressure through the same basic mechanism as pharmaceutical calcium channel blockers, but in a physiological, gentle, and broad systemic manner. Magnesium deficiency, which surveys suggest affects the majority of people consuming modern Western diets, is associated with increased arterial stiffness, elevated inflammatory markers, impaired insulin signaling, and elevated cardiovascular risk. Magnesium-rich foods, including leafy green vegetables, nuts, seeds, and legumes, should constitute regular components of any cardiovascular health strategy, and supplementation with well-absorbed forms, including magnesium glycinate or magnesium malate, is a reasonable consideration for many individuals. Nattokinase is a fibrinolytic enzyme derived from the traditional Japanese fermented soybean food natto that has generated significant scientific interest for its ability to directly break down fibrin, the structural protein component of blood clots. Blood clots forming on top of existing arterial plaque are the immediate proximate cause of the majority of heart attacks and strokes. A plaque that has been building for years suddenly becomes fatal, not simply because of its size, but because of the formation of a blood clot on its surface that completely obstructs blood flow. Nattokinase has demonstrated in clinical research the ability to reduce fibrinogen levels, reduce D-dimer markers of clot formation activity, and improve parameters of arterial stiffness. Its mechanism is distinct from and complementary to pharmaceutical blood thinners, and while it should not replace medically indicated anticoagulation therapy, it represents an interesting and evidence-supported natural tool in a comprehensive arterial health strategy. Aged garlic extract has accumulated a genuinely impressive body of clinical research supporting its cardiovascular benefits. Multiple randomized controlled trials have demonstrated that aged garlic extract reduces the progression of coronary artery calcium scores, one of the most objective and meaningful measures of arterial plaque burden available through CT imaging. Aged garlic extract contains organosulfur compounds, including S-allylcysteine, that reduce inflammation, inhibit LDL oxidation, improve endothelial nitric oxide production, reduce blood pressure, and demonstrate antiplatelet effects. The clinical trial data on aged garlic extract and coronary artery calcium score progression is among the most compelling evidence available for any nutritional intervention directly targeting existing arterial plaque. Vitamin K2, specifically the menaquinone 7 form, plays a fascinating and critically important role in directing calcium away from arterial walls and toward bone tissue where calcium belongs. The arterial calcification that characterizes advanced plaque, visible on CT scans as the bright white deposits that radiologists use to score cardiovascular risk, represents calcium that has been misrouted away from bone and into soft tissue, including arterial walls. Matrix GLA protein is a powerful inhibitor of arterial calcification, and matrix GLA protein requires vitamin K2 to become activated. In K2 deficient states, which are extraordinarily common because K2 is found primarily in fermented foods and certain animal products that are underconsumed in many modern diets, matrix GLA protein remains inactive and cannot perform its arterial protective function. The Rotterdam study, a landmark prospective epidemiological study following thousands of subjects for a decade, found that the highest quintile of vitamin K2 intake was associated with a 57% reduction in cardiovascular mortality compared to the lowest quintile, a statistical finding of extraordinary magnitude that has received far less mainstream attention than it deserves. Exercise, specifically a combination of aerobic cardiovascular training and resistance training, is the single lifestyle intervention with the broadest and most mechanistically diverse array of arterial benefits. Regular aerobic exercise performed at moderate intensity for at least 150 minutes per week, or vigorous intensity for at least 75 minutes per week, according to major health guideline bodies, has been shown to reduce arterial stiffness, improve endothelial function, reduce inflammatory markers, improve lipid profiles, improve insulin sensitivity, reduce blood pressure, and reduce the risk of major cardiovascular events by 30 to 50% compared to sedentary lifestyles in multiple large prospective studies. Resistance training adds complementary benefits, including improved insulin sensitivity, maintenance of metabolically active muscle mass, reduction in visceral adiposity, and improvements in blood pressure independent of those achieved through aerobic training. For individuals who are completely sedentary, even modest increases in physical activity, walking 30 minutes per day, taking the stairs, breaking up prolonged sitting, generate measurable cardiovascular benefit. The dose-response relationship between physical activity and cardiovascular health is not a threshold phenomenon. More movement generates more benefit across the full spectrum of activity levels. Smoking cessation is, without any qualification or nuance, the single most impactful cardiovascular intervention available to people who smoke. The oxidative damage inflicted on the cardiovascular system by tobacco smoke is profound, systemic, immediate, and cumulative. Every cigarette delivers thousands of free radical species directly into the bloodstream, directly damaging the endothelium, directly oxidizing LDL, directly promoting platelet aggregation, and directly elevating carbon monoxide levels that reduce the oxygen carrying capacity of blood and promote arterial inflammation. Smoking doubles, triples, and in some populations quadruples the risk of cardiovascular events compared to non-smoking. And the remarkable biological truth is that the cardiovascular system begins recovering from smoking damage with surprising speed after cessation. Cardiovascular risk begins declining within months and continues declining for years following cessation, demonstrating the genuine regenerative capacity of the arterial system when the source of injury is removed. The concept of arterial inflammation and plaque reversal, actual regression of existing plaque, is one of the most hopeful and most substantiated findings in modern cardiovascular research. For decades, medical thinking assumed that once plaque formed, it was essentially permanent, a structural change in the artery that could be managed, but not meaningfully reversed. The evidence accumulated over the past 2 decades tells a different and far more optimistic story. Multiple clinical trials using intensive lifestyle modification, combining aggressive dietary change, regular exercise, stress reduction, and social support, have demonstrated measurable regression of coronary artery disease. The landmark work demonstrating that a program combining a whole food plant-based diet, regular exercise, stress management, and group support produced measurable reversal of coronary artery blockages in patients with established heart disease represented a paradigm-shifting demonstration that arterial disease is not simply a one-way biological street. High-dose statin therapy combined with lifestyle modification has demonstrated plaque stabilization and modest plaque volume reduction in multiple imaging studies. And emerging research on therapeutic approaches targeting inflammation directly, including specific anti-inflammatory interventions, has demonstrated that reducing inflammation independent of changes in cholesterol levels reduces cardiovascular event rates, providing perhaps the most direct experimental confirmation that inflammation is indeed a causal driver of cardiovascular disease progression, rather than simply a correlative marker. What began today as a question, what really damages your arteries, has been answered with the full weight of modern cardiovascular science, and the answer is both sobering and genuinely empowering. The real enemies of your arterial health are chronic inflammation, oxidative stress, glycation from elevated blood sugar, insulin resistance, chronic psychological stress, sleep deprivation, physical inactivity, dietary patterns dominated by processed and inflammatory foods, and the cumulative daily decisions that either accelerate or arrest these biological processes. The cholesterol narrative, while not entirely incorrect, has been dangerously oversimplified in ways that have led hundreds of millions of people to focus on a single biological variable while ignoring the broader inflammatory and metabolic environment in which cholesterol becomes dangerous. The truth is more complex, more interesting, and ultimately more actionable than any single variable explanation could ever be. The most powerful message that emerges from everything we have explored today is this: your arteries are not passive victims of inevitability. They are dynamic, living, responsive biological structures with genuine capacity for repair and regeneration when the conditions that support healing are consistently provided. Every meal that reduces your glycemic load is an act of arterial repair. Every night of adequate deep sleep is an act of endothelial restoration. Every session of physical movement is an act of nitric oxide production and vascular renewal. Every reduction in chronic stress is an act of cortisol normalization and inflammatory calming. Every cigarette not smoked is an act of endothelial protection. Every quality omega-3, every dose of magnesium, every serving of aged garlic, every adequate intake of vitamin K2 is a contribution to a biological environment in which plaque formation slows, stabilizes, and in time regresses. The human cardiovascular system is more resilient than the medical establishment has historically communicated, and the science of arterial health gives every individual reasons for profound optimism alongside profound responsibility. You now understand what most people will never understand about their own cardiovascular system. You understand the real mechanisms, the real drivers, the real solutions. That knowledge is not passive. That knowledge demands action, not perfection, not overnight transformation, but consistent, informed, daily movement in the direction of arterial health. Start somewhere. Start today. Start with one meal, one earlier bedtime, one walk, one deep breath. The arteries you save will be your own.